Hello, everyone, and welcome to an Unfiltered production with me, Sherry Teague, and Cindy Krafft from K&K Healthcare Solutions. And we have an interesting topic today. Last week on the March 11th, they had a hearing, and it was a hearing about post-acute care. And that's why the title of this Unfiltered podcast is They Had a Hearing, But Are We Listening? And we wanted to start with the macro thoughts that were brought up in the hearing, and we wanted to bring it down to the practice level so that you kind of understood where some of the conversation was coming from and what it has meant to you in your practice and in running your agency. So the Impact Act of 2014 is the Improving Post-Acute Care Transformation Act of 2014 was meant to come up with a unified payment system across the post-acute settings. Cindy, can you explain what they mean by the post-acute settings and what has happened as a result of this act that went into effect 11 years ago?
Well, some of you may remember there were a lot of visuals, I think, used that looked like trains in terms of what was going to happen at certain date time points to get us all on the same page. And all of us would be skilled nursing facilities, long-term acute care hospitals, inpatient rehab, and home health. And that's where some of you may have heard me, refer to our setting as the caboose, because we were always the caboose in the visual. It was like, we're going to take care of it here, 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 and eventually you. I think that kind of gave us a sense of a delay. It'll get to us eventually. Maybe they'll work the kinks out ahead of time. We saw the evolution of a care tool. And that got a lot of traction about creating a unified document that at that point was intended to replace OASIS, the IRF-PI, the MDS in the skilled nursing facility. And then it kind of started to come apart. They were realizing that having a tool with all the identical questions in those four settings was not working as intended, because we know that there are varying degrees of patient impairment and medical condition and support services and all of that in all of those. And so the idea of using something that was 100% identical just seemed to fall apart. And I think what happened there, those of you that were, aware of the care tool or maybe went to some trainings, kind of dug into it, I think we all collectively felt it died. I mean, the whole idea is dead, right? Because you go to a conference, nobody's talking about care tools or that anymore. I mean, it's just fallen off. And so I fell into that same, I guess we've moved on from this. I mean, we see where they're trying to make more cohesiveness among the tools, like adding the GGs to ours, because GGs are in the skilled nursing facility, inpatient rehab, and long-term acute care hospitals. We also see that some of that alphabet soup that got added when we went to OASIS E, where everything stopped being an M item and we got other letters, if you dig into other settings tools, you will see that's where that stuff is coming from. So there is that move towards standardization from data collection. So what does it have to do with the hearing? Well, I sent Sherry the original link to the hearing. Whoop, yeah.
Because it's a post-acute, the Impact Act is about the post-acute providers, but
Yes.
a couple of post-acute providers were missing from that. You did not say hospice or outpatient.
No, hospice and outpatient were not part of that conversation. But yes, when you think about literal post-acute care, hospice definitely falls into that. And I would argue inpatient rehab, although they're not inpatient, outpatient services, although they're very often not in the conversation. They don't have the GG item push. They don't have those other things, but we'll see what happens with time. But sending that link to Sherry, I did it with kind of a, should we go? Because, it's a government thing. It's going to be about post-acute care. And is it really going to talk about home health? You kind of go in, you want to protect your own. They better say something about home health. They better say something good. I really don't want to sit here and listen to the discussions of skilled nursing facilities and everything else. I was shocked at that conversation and highly recommend, if you have the time to listen to it, I would do so. Listen to the recording. It was very eye-opening.
To the recording with this podcast, so everybody can have a chance to listen to it.
And yeah, you look at it and say, oh my gosh, is it like 2 hours? Well, you can do it in parts. The beauty of a recording is you can stop and come back to it later. But one thing that just dropped my jaw was the discussion of bringing back the unified payment system.
Right.
as the solution for cost savings in post-acute care. I almost fell out of my chair, Sherry. I'm like, No, they did not just say bring back the unified payment system, especially in the tone of like it's magic. It
Yeah.
will fix all our ills. And I'm like, did you just show up? Did somebody bonk you in the head? No offense to the individual presenting this, but we've seen nothing to date that says it's the magic solution to control costs in the post-acute space. So why are we bringing it up here? The fact it was mentioned more than once, I think we've got to get this idea of a post-acute payment methodology, some sort of unified, back on our industry radar.
Yes.
Because I think what would happen is if they proceeded, we'd still be the caboose. We would still be the problem child who has all of the factors at play that facility-based care does not. But I think we're going to have to be our own advocate. With the loss of the open comment periods, with how would I make my voice heard, we're going to have to make sure we're informed. Because I'm concerned, Sherry, that if we've all decided that whole thing died a death a long time ago and doesn't really concern me, that could absolutely come back to bite us. Now, I'm not saying we're all going to go dig out the care tool and spend hours training, not that, not go the other end. But ignorance might be bliss temporarily. I don't think it's a long-term strategy because you and I talked about this. I was not expecting that to come up at all, let alone out of the gate that quickly as a proposed solution.
It felt like the individual that was there with a job, and their job was to bring it back into the conversation. And I was really pleased with the level of the expertise on the witness side. I think that they got some really good providers and they had a very good discussion. And I think that hospice was talked about a lot in that hearing, and it should be. Hospice is under a microscope right now because of the increase in the number of providers, the types of care that are being provided, who's purchasing those agencies. All of those things are in that conversation. But I think the thing that frustrates me, Cindy, and the thing that every time I get on one of these hearings, I just want to yell through the computer screen, and to anybody that will listen, and anybody that's heard us speak before, they know we are big home health advocates, and home health is its own setting. It is not, yes, does it happen after an acute care stay? No, not all the time, probably half the time. The other half, it's a community referral. So if it's a community referral, that becomes post-acute. How? Because it never came from an acute care setting. And so we keep hearing all these mashed up words, skilled nursing at home, hospital at home. And I want to be really clear. Home health is its own beast. It is its own setting. It is unique to any of the others. The closest is probably home-based hospice. That is the only one that has to go into a home environment or into an environment that is all across the map. You never know what you're going to walk into when you walk into someone's home or someone's dwelling, right? And so in home health, they don't even have our data correct. Am I right? And when they're making these calculations, you've been around technical expert panels. How are they doing at gathering home health data and comparing it to other settings?
Well, what's been interesting on some of those panels is that they're able to report off data for SNFs, IRFs, and LTACs, but then the column for home health, at least in my most recent interactions, remains blank. They have it, they say they're analyzing it, but that's what really concerned me pulling the GGs into VBP is what is our baseline? We didn't even get a baseline to be able to even ascertain our current state. It immediately went from, yeah, it's in there to, yes, it will affect your payment without giving us any sort of, yes, there's that whole, you could call it practice. But anyway, we never got a chance just to figure out where we were before it became a payment related issue. And I think that has to do with, I've irritated some people by pointing out when it says in a corridor, you clearly don't mean home care, right? I'm sorry. Your verbiage screams facility. And your distances, and we're both in physical therapy, Sherry. We know gait is a big deal, but we also know there's been so much. If you walk more than 150 feet, you're going to burst into flame and not be homebound. How did that number end up as the largest distance available? Why? Because 150 feet would be a big goal for LTAC. A reasonable goal for SNF and IRF to get them out. We're at home. Where are you going to go with your 150 feet? You're not going to get anywhere. So you look at that and you say, yeah, I get the idea, but home health has these extra things, like the fact not only is each dwelling situation different, we can't change it. We can't go in and, set up a new protocol, move the furniture, get rid of the pets, clean you can't. So you have to work around things that are important pieces of information, but not manageable the same way facility-based care can do. But what I thought was interesting to me, Sherry, is again, I went into it as I think we all would. Home health. We're going to protect, you better say good things about home health. And they did. I echo the representation of post-acute care that testified was excellent. I mean, they made great points. They definitely called out Medicare Advantage very professionally, but very clearly. And they also acknowledged that we have the proverbial bad apples in all our settings, recognizing, let's just be realistic, no setting's perfect. We've got issues. We want to work on those. But I found the discussion of the long-term acute care hospital, the LTAC individual, incredibly enlightening. And it made me think, not only is this whole issue of, healthcare as a business part of the problem, is we're almost set up to compete with each other about who goes to what setting. And listening to the LTAC talk about how, they could assist hospitals with bed capacity issues of patients that are definitely too sick to go to a skilled nursing facility and definitely not go home. But hospitals don't have the room. People are sitting in hallways. People are kept in ERs, extraordinary amount of time for bed capacity. And yet LTACs can be few and far between. Some of you watching this may go, I don't even know what that is. Because especially, looking back at the OASIS and where the person comes from, it does say long-term hospital. That isn't about their length of stay, it's about their designation. So to be an LTAC, you have to be designated as one. And there's entire regions of the country that don't even have any. But I got to thinking, wait a minute. So if the hospitals are scrambling and have people that are too sick to go somewhere else, but they can't house, why would there be not more attention to funding and creating more LTACs and revisiting what are the criteria to be in one, not random things like I'm on a ventilator, so then I can go. Really, that's your big criteria? Just like, oh, I can go to a nursing home because I was in the hospital 3 days. The 3-night thing, is that really getting it? So, Sherry, I could go on about this way longer. I just want to boil it down to it enlightened me to say, yes, we need to be very strong advocates for our setting, but maybe the larger discussion needs to be not a unified payment system, but a reevaluation of what are the criteria in our current state of medical technology, advancements, disease management, all of that. And say these arbitrary 3-night stays or vent or no or homebound, maybe we just need to reevaluate all of those settings and determine what is the best criteria for the individual patient, which one should they be in? Because right now, I think it's being more dictated by availability, Sherry.
100%.
Somebody needs that bed in the hospital. They got to get them out of the hospital. I called all the nursing homes. They don't have a bed either. I'll go to home care. Is that really the right setting necessarily? Or is that the one person that went, oh, okay, I'll take him?
Well, and let's be frank, Cindy, they'll send them to home care, and home care has what, a 60% chance of not taking them under care?
Mhm.
So we have our own issues within our borders of home care that say when a patient gets referred for home care, only 40% of the time are they going to receive the home care that they were referred for. And that's due to some of the cherry picking that's going on in our industry. And I hate that's going to open up a big old can of worms, Cindy, but I'll say it very frankly. We're assessing those patients via their data, what diagnosis they have, what prognosis they have, before we ever take them under care to see if they're going to be profitable. So I told you I would not get through this conversation without saying that we profit off of healthcare in this country. And that says a lot about me, possibly politically, but I hope it doesn't. I hope it screams for my humanity. I really truly believe that that's one of our human rights, is to have health and the right to liberty. I think you can't have liberty without health, right? And so,
Right.
in coming up with a way that we can take care of these patients in the appropriate environment is so important, but also paying for that is super important, and paying for that in a consistent manner. And I think that what was brought up about Medicare Advantage was not surprising to anyone. I was really surprised with the venom that some of the lawmakers came at Medicare Advantage, because Medicare Advantage costs the Medicare program more money for less care, period. End of conversation. And we're seeing a unique thing in home health that's occurring over the last couple of years. The Medicare Advantage provider or payers are now becoming providers. In what space? That's right, you guessed it, home health. I think that says a lot of things about where some of these dollars may be concentrated in the future, and understanding that we will be competing with the same people that are paying us, or we are currently competing with the same people that also provide patients to us and pay us on occasion, and also set those pre-authorization standards of whether they're going to get the care. The most powerful thing that was said in that hearing to me was when the gentleman, and I can't, his name is off my head, but if you go to the hearing, it was very, very interesting. You have patient A in one room and then patient B is across the hall. Patient A has traditional Medicare, patient B has Medicare Advantage. They present exactly the same way. Patient A with traditional Medicare will go to the setting that they're supposed to go to in a very fluid manner. They'll spend their time in a hospital, they'll go to a long-term acute care facility, skilled nursing, home health, wherever they're supposed to go without any impedance. Whereas the Medicare Advantage patient has to sit and wait, and they have to wait on an authorization. And it was interesting, the question they asked was, what happens to that patient in the interim? And I think to a person, every person on that witness panel went,
The silence, those moments of silence were deafening about what happens in that situation where you're waiting for prior auth. What happens when there's capacity issues? What happens to the person who can't get into the skilled nursing facility because there's no room, who can't get picked up by home health because of a staffing issue? I mean, with the new COP, we have to disclose our criteria for staffing and how we're admitting people. And if we can't do it in a certain amount of time or don't have these services, we have to let them know. But the question of then what happens, the silence was just deafening.
well, they
Because
talked about 13,000 people a year are dying in those situations waiting for their care to be authorized. I mean,
Well, no, that was the 13,000 was the issue of the skilled nursing facility and the pushback about them being required, though it's in law, it has not started yet. Many are trying to advocate to get rid of it, but it's minimum staffing standards basically for skilled nursing facilities to indicate that they need to have X number of nurses, X number of nursing hours, and that could be a whole other podcast, Sherry. The first time I heard skilled nursing facilities were mad that they were being made to have a nurse on site. I was like, that is one of the craziest things I've ever heard. You're called a skilled nursing facility. Kind of thought that meant you had one. And that was the whole big, so-and-so can't go home because we are a nursing facility. Well, if the nurse isn't there either, we can take them at home. I mean,
to be clear, they're staffing that with LPNs. They're staffing that with the lower license, less expensive nurse alternative, which is not the alternative for an RN. Someone at that level of skill and expertise literally would save lives in that 24 hours in that skilled nursing facility.
well, and that's the data they presented, that 13,000 lives per year they can say are saved when you have access to RN at these minimum staffing standards in a skilled nursing facility. And to have that kind of blown over, I'm like, that's 13,000 grandmas, grandpas, aunts, uncles, brothers, sisters, and we're just going, it's too much work to put that. But again, I mean, I would highly recommend people listen. It touched on a variety of important issues. And did it change anything? I wouldn't say it changed anything right then. They didn't like run off and change the laws and do all this stuff to it. But I think there's times we need to understand our lane, but also look at the lanes next to us. Because if we just die on the hill of home care is the pinnacle and that's all I'm going to be informed about, we're very limited. And our clinicians need to understand that don't scare them with the care tool. Don't do that though. We already have staffing problems. But recognizing how important those OASIS questions are, no matter what the letter is in front of them, we need to be generating consistent, accurate data. It's going to end up somewhere. It's going to end up in outcomes. It could end up in this new payment idea. And what we can't do is what we've done historically. Focus on only some of the items because they're important. And then when something gets added, oh, now we worry about this. So we collected years of data one way and then pivot because now it affects reimbursement. Now it's an outcome issue. I think that fuels some of the attitude we saw about, no, you guys are making money.
Mhm.
And yeah, there was back and forth about the accuracy of profit margins, but it still factors into it. We got to make sure the clinician is really collecting good data and that the reviewer is ensuring the entire document is defensible and accurate.
And Cindy, that brings me to my other pain point. When the MedPAC data was brought up about MedPAC recommending cuts in post acute care every year, especially in home health, it was brought up that that data was not accurate because it doesn't include the Medicare Advantage payment or outcome data. And the person who was advocating for the post acute unified payment was very happy to say that they really truly 100% believed in the data that MedPAC was looking at.
Yes, there was no need to revisit how MedPAC calculates things. And it was like,
Which indicates that home health agencies are making a what profit? 20% or
yeah,
better?
the numbers they were citing were again, kudos to the representatives there for these parts of the healthcare continuum. I don't know if I could have controlled my face that well or probably got myself kicked out with, what do you mean, MedPAC's infallible? I don't know. I think
And
I
then,
think there's value in how can you keep saying all these horrible things, particularly we'll just use our setting as an example, when we can clearly say, but you don't include this, you don't include that, you don't look at this. And I think one of the points along those lines about margins in money was the individual who brought up how many of these rules force entities to hire more clerical office people, to juggle all the paperwork to be compliant, and not the people that go care for the patients.
right.
So I keep getting higher and higher internal costs to be compliant with your rule that impedes my ability to hire actual clinicians who actually go out and care for these people because I have to keep incurring a higher and higher expense to make sure that all of these I's are dotted and T's are crossed. So there was a lot of food for thought in that. And I'm really glad I went.
You opened it up. You talked about what would happen at the clinician level in the home health agency. So I wanted to bring it down to the clinician level. So you might have listened to this entire podcast and you're a clinician out in the field, you're listening to it in your car and you go, what does this matter to me? Well, I'll explain what it matters to you. Over the last, probably since this bill has gone into place, I can say that we literally have seen sicker patients every year come into home health. We've seen patients with higher acuity levels. I know as a coder, I've seen the code sepsis being used in home health more than I've ever seen it over the last year or 2 years. And that before, sepsis was assumed that they wouldn't be a home health diagnosis because they should be in acute care and in a hospital-based system. So we're seeing sicker patients. We're seeing them with less resources, especially in a Medicare Advantage patient. We're only given a certain number of visits. And on a day-to-day basis, as clinicians, we're being asked to choose between what is best for the patient and what you're able to do. And I say that as a clinician, you're sitting there across from a patient. Oftentimes you go, I am the best person here to help that person. I have the expertise, the skills, and the tool availability to get them better, to get them to the next level. But sometimes you sit across from patients and you're like, why are they home? What they need more help than what can be provided here. You have to, as a clinician, identify that and report it back and scream it from the mountaintops to make sure that these folks get to the level of care that they need. So that's where it comes in, that day-to-day face-to-face when you're in front of a patient. You as the clinician are their best advocate. So Sydney.
And I think along those lines, Sherry, we've been saying for years that the patients in the home health space are getting sicker and sicker. But then we do documentation audits at K&K, and I see care plans that are so cookie cutter, it drives me crazy. It's the exact same interventions on every person who has diabetes, the exact same ones on everybody who has heart failure, the same frequencies, the same duration, basically the same goals. And this is where I flip my position and say, if I'm on the side of the payer, and you tell me, oh, it's so complicated, it's so hard, they're so sick, they don't have caregivers, and they have dementia. Well, I'm looking at your utilization, and it's no different than the patient through their coding didn't have any of those conditions noted. So being very objective, I'm not going to give you more money because you're not spending more on these more complicated patients. And I know it's a vicious cycle. If I overspend too much right now, I'm going to go broke and I can't serve anybody. I understand the balancing act. But I think those moments of does my documentation reflect the complexity of the care I provide? If we see a comprehensive assessment and it's got dementia and a caregiver in question and all this other, and then I look at the visit notes and nobody ever mentions it again. Therapy comes out in the evaluation, says nothing. We note dementia, but the same teaching and training and all this happens, and apparently they recall task directions fine and all of this. And it's like, what are you doing?
Yeah.
What are you doing? Take that extra moment, and I'm not saying moment, I'm not saying war and peace, and say, at least in my little summary of that visit, do I acknowledge the unique complexities of this individual that I was there to deal with? I didn't just do teaching. Teaching is different in every house. Training is different in every house. Med education, whatever it is. But I think we've watered it down. And then that's how we're communicating to payers. That's what they read. That's what they pull for TPE and ADR. And that's when they say,
Yep.
I get you waving your flag, but I'm not seeing it in the actual day-to-day care delivery. And I think it's because we get busy and we know, and I'm not saying, it's intentional. We're busy. It's an EMR. We can click it. It just shows up. It makes everything. But are we taking that advocacy? Sometimes I think, Sherry, advocacy, people get like, well, I'm not going to go march on Washington. I'm not going to call my senator. But patient advocacy is in those daily visit notes.
100%.
Why am I there? Why did I have to be there? And if patients are missing visits for whatever reason, does that affect your care plan? Because it doesn't look like it. You miss a visit, next visit, pick up where you left off. They did perfectly fine without you for a week. Did they?
And you may get in Cindy's voice that she just finished an audit where she saw a lot of cut and paste, and the agency actually denied and thought that their clinicians, no way would they cut and paste, and the problem was there was punctuation errors or straight
Typographical errors in the same spot.
in the same spot every time.
That
So
drives me crazy. But
that
anyway,
that kind of stuff is low hanging fruit for an auditor. But thank you guys so much for listening to this extended podcast on this hearing. And again, if you have any other questions, subscribe to our emails, and all of that information will come through. And hopefully we'll see you at our free Q&A this Thursday at 1 p.m. Eastern. And you can find out more about that in our newsletter as well. Cindy, do you have any final thoughts?
no, I don't want to get riled up and add more time. I'll
Have
save it for the Q&A on Thursday.
There you go. Have a wonderful day, everyone, and be safe out there.